Come on, give me my share. There we go. It's having a moment. All right, somebody needs to mute themselves because it sounds like they're stuck in a small hurricane. Hold on one sec. All right, so abdominal trauma. Quick review in case you forgot what goes on in an abdomen. You have a number of very tightly packed and relatively important organs that hang out inside your abdomen. Remembering where these things live is kind of essential when you're dealing with both blunt and penetrating trauma to the abdomen. Your upper quadrants are a little bit more in the super bleedy kind of world, whereas the lower quadrants, you're really going to be more concerned with like bowel perforations and widespread sepsis because of leaky gut problems. Also, a lot of those hollow organs can hide a lot of blood, okay? You can live without your spleen, but your spleen can hold, I think it's up to about 1 liter of blood in the event of emergencies. So if you have someone who has a some sort of shock scenario going on, the spleen will actually deploy a number of extra red blood cells to kind of help improve oxygenation. While penetrating the trauma does tend to have a higher mortality rate just due to the amount of bacteria that lives in your gut, blunt trauma tends to be associated with multiple organ injuries, okay? So if you have someone who has who is presenting with shock, it's really kind of unspecified shock-like symptoms. In the event of abdominal injury, you really want to focus in on that being your main cause. Because again, you can hide a significant amount of blood in an abdomen without showing a lot of other signs and symptoms. You might get some abdominal distension, some rigidity, but it's going to take a little while for like the 2 and 2, right? So like, oh, you got hit by a car, you may be distracted by like a significant femur fracture or something, but oh wait, just kidding. They also lacerated their liver and they're bleeding out internally. Blunt trauma is a combination of compression and or shearing forces. So when you have the compression, the organs get crushed, obviously. But the shearing forces, right, like we talked about with the heart when it's dangling on the aorta, especially with the liver, right, as it starts to kind of either decelerate or experience a new acceleration after being hit by something, most of the time those solid organs start to kind of tear or shear along points of attachment. So a lot of those we talked about before, a lot of that fetal circulation that gets turned into ligaments kind of serves as like a cheese cutter, right? That really thin line where it kind of garrotes the entire organ and just starts to kind of create a lot of vascular injuries along that region. Blunt trauma is really very commonly associated with motor vehicle accidents and pedestrian struck, right? Because that's usually the acceleration, deceleration forces that are very commonly associated with that. Penetrating trauma, on the other side, is usually due to obviously being poked by something you're not supposed to be poked by. It could be a gunshot wound, it could be stabbing, it could be an impalement, it could be a variety of different things that are causing the penetration of the abdominal cavity. But obviously hemorrhage is going to be a significant concern, as well as infection, right? Because we talked about this. There's actually a book that it says I think it's I Can Contain Trillions, I think is the title of the book, and it just talks about all of the trillions of bacteria that live within your gut biome, right? And they're responsible for a lot of things like helping you digest, helping you break certain components down into digestible parts, as well as vitamins and coenzymes and such like that. But once they find a doorway out into your abdominal cavity, sepsis is a significant problem. We actually had this at Garden City a few weeks ago. There was a woman who had elderly woman, had a history of a hysterectomy. New onset of spontaneous vaginal bleeding, which when you're in your 90s and you don't have a uterus is usually a concern. So she went to her GYN oncologist, who went and did the whole evaluation and saw a lesion. Decided to take a sample of the lesion. So he did a biopsy. Woman started experiencing significant abdominal pain like right away. She's like, something's not right. And they're like, no, it's just because of the biopsy. Sends her home. She has intractable abdominal pain for 3 days. Starts having altered mental status, rigid abdomen. Family calls the ambulance. We get her, pick her up, right? Go to the hospital. It turns out that they perforated her bowel through her vagina, which probably means that after the surgery, her intestines had adhered to it, and that lesion was her intestines and vaginal wall starting to create like a fistula in between. And she died from sepsis. What happened? Oh, my internet connection is unstable, apparently. Curses. All right. Yeah, we're all a little unstable. Where was I before? They perforated her bowel. So what I'm thinking was after her initial hysterectomy, which is very common, is that extra space, your intestines kind of settle in, right? If you have two organs that lean up against each other, they tend to create what's called a fistula, because they start to adhere to one another and then just start to share vasculature, and then they create an opening. So I'm thinking that the lesion that they had biopsied was actually the beginning of a fistula. And then when they took the biopsy, they perfed her bowel, and then her entire abdomen filled up with her bacteria biome, and she turned into a giant bowl of sepsis. So she actually ended up dying from sepsis. Yeah. Moral of the story: doctors kind of suck sometimes. Zach, you want to take over? All right. When the liver is injured, it is a very significant injury, okay? Your liver is highly, highly vascular, okay? It literally filters all of your blood. So there's a significant amount of blood inside your liver at any given point of the day. If you have any sort of trauma from the 8th to the 12th ribs on the right side, there's going to be most likely an associated liver injury. Also trauma to the upper part of the abdomen, right, that upper quadrant, also highly, should have a high index of suspicion for a liver injury. The problem with the liver is if the gallbladder is injured as well, it will start to release bile into the peritoneal cavity as well. So bile is a digestive enzyme. So as you start to self-digest yourself, you will have a lot of peritoneal irritation, a very rigid abdominal wall, on top of a significant amount of blood loss. So whereas your liver is on the right side, your spleen is on the left side, also protected by the ribs. A lot of patients who have spleen injuries don't necessarily have symptoms. The most significant symptom that you will have of a splenic injury is usually status post blunt force trauma, is vomiting. There's also kerosene, which I'm really hoping I have nope. I don't remember what kerosene is right off the top of the head. I believe that it's radiating pain to the left shoulder, I believe, is kerosene. Harder to have a splenic injury because it is relatively well protected, but again, significant rapid blood loss. Your stomach, again, usually relatively well protected. It's covered mostly by the liver and the ribs, right? So you have the ribs that kind of hang out. Let me get you a little doodle here. You have the ribs that kind of hang out over here. Hold on. There you go, right? So you got some ribs. So most of the stomach is relatively well protected from injury. It's also hollow, so it's not very commonly very full, and it's not full of air, so it kind of collapses upon itself. So it's not going to experience the same kind of like balloon damage that you would expect with like lungs, which are frequently full of air. The problem with the stomach, though, is that if it is perforated, like for example from a penetrating injury, the did you guys lose me again? The acid is going to cause, again, that peritonitis, that peritoneal irritation. In the event of a stomach perforation or an injury, it's got the highest mortality rate of all the other hollow organs, right? Because of that acidic component. We talked about this already, right? The colon and small intestines, a lot of bacteria that live in there. If it is a penetrating injury or some sort of compressive forces that cause a level of rupture, that bacterial leaking into the peritoneal area can cause significant sepsis. Again, you'll see that peritonitis, that irritation, and sometimes abscess, which is always a fun experience. While we talk about the abdominal organs, we also have your retroperitoneal organs, which is really the most significantly going to be your kidneys. Okay, they exist in that space right behind your abdominal wall. They are relatively well protected, again, by the ribs. They are kind of up by the level by the like right around where the liver is. Okay, so if you think like kind of straight back from the liver, that's sort of where your kidneys hang out. If you do have injuries to these organs, it tends to be pretty significant. Okay, again, your kidneys are hanging there by, you know, the arteries. So if they're sheathing, or sheathing forces can create a significant problem if those attachments are torn. A lot of the times patients will experience like a bruised kidney, so they might experience like blood in the urine. If it is a significant laceration to the kidney, you may have extravasation of the urine from inside of the kidney, right? So that might cause, again, a lot of irritation, a lot of sepsis and other concerns. A lot of the other organs, such as like your ureters and your pancreas and your duodenum, right? So your duodenum is here up top, going across. They are all relatively, here's your pancreas, right? Here's your pancreas is hanging out here. Your duodenum is right here, okay, right? Again, you have the ribs, which are, hold on, get a different color for you. Wrong one. You have the ribs, which kind of protect down this way. So your pancreas is relatively well protected, as is the duodenum. The ureters are deep within the body and kind of floating in between. They're back here. It's this challenging color scheme here. I hope no one's colorblind, because you're not going to see anything. You have the ureters over here, right? So these are relatively well protected because they're not very much, like, they're not anterior, they're not posterior, and they're not near any of these bony structures that may fracture and cause injury. If you do happen to have injuries to any of these, they're usually, the pancreas and the duodenum are usually injured together, but again, very much kind of well protected. Your pelvic organs are definitely going to be higher risk in the event of a significant pelvic fracture. Again, remember, your pelvis is relatively strong because of its shape, right? So it's very challenging to actually break a pelvis unless you are involved in a very high-speed injury, or there's some sort of other pathological concerns, such as like osteoporosis. Again, a lot of these organs, though, are hollow, so they do have some resistance to compressive forces. But if, for example, the bladder is full, you might end up with a patient who experiences a ruptured bladder due to those compressive forces. Or again, you always have the concerns of penetrating injuries. Urethra is commonly more injured in men, which I'm going to say is most likely due to sexual trauma, right? Where they end up kind of fracturing their penis and causing damage to the urethra. Difficulty voiding is one of the number one ways to kind of determine that there is either a bladder injury or a urethra injury. Again, relatively rare. Again, in females, a lot more rare than in men because internal versus external. There are, obviously, through the abdomen, you have very significant vascular structures. Your aorta, your inferior vena cava, you have your renal arteries, your mesenteric arteries, your iliac arteries, and veins, okay? All of these are the arteries are very high pressure. The veins are very large vessels, okay? And there's a lot of blood moving through this section. So there's a very high mortality rate associated with any of injuries to these vessels in particular. And there's not a lot that you can potentially do to control that kind of bleeding. You may or may not have a patient who you will experience a pulsating abdominal mass if this is injured. Depending on your response time, they may already have died before you even get there. One of the easiest ways to determine that a patient has abdominal trauma is unexplained shock. Okay, you have a patient who has had some sort of injury and they are hypovolemic, tachycardic, maybe altered mental, and you're like, I don't know where it's coming from. Probably the abdomen, okay? It takes a little bit of time for bruising to develop. So if you have somebody who is guarding the abdomen, right? So maybe they're not moving, they're protecting it, they're kind of holding everything in. There's a good sign that there's bleeding going on there. Evisceration is probably the easiest and most obvious. Rib fractures are also have a potential to cause a lot of, especially the lower ribs can cause injury. Because if you look at this gentleman here, you can actually see here's the line of his ribs, okay? So you have, like, right here is his spleen, and you have the stomach. It's going to be like right here. And then you have your liver. It's going across this direction. So if this had happened a little higher, it's a possibility that all of these intestines that are kind of popping out right here may also have been accompanied by the stomach, okay? But again, these ribs serve relatively decent protection for a lot of those really kind of vascular abdominal organs. Again, if you look right here, this is his pelvis also, right? So there's the iliac crest. So he got, wherever this injury is right over the iliac crest, which means that all of the pelvic organs are probably a little bit safer. So if this was a female, things like her ovaries would be a little better protected because you have that bony ridge of the pelvis. When you are assessing abdominal patients who have potential abdominal trauma, there's a lot of different things, obviously, that you're going to want to get a good history of. Seatbelts, right? Because we talked about this in the chest trauma. Seatbelts can cause significant damage if not used appropriately. Even if they are used appropriately, high-speed accidents can cause significant contusions and bruising. And especially you have that lap belt that goes across, can also cause some level of abdominal trauma. Where was the patient, right? Back seat, front seat, were they on the side where the impact was? Was there any potential alcohol or drug use, right? Because any patient who may be impaired by alcohol may have a lower ability to clot, so they might bleed more. Underlying medical issues, right? Alcoholism, hemophilia, medications, right? High blood pressure, diabetes, all of these things factor into your focus history. And obviously allergies, which is just a good question. Unfortunately, abdominal trauma is not something that we can really do much for, right? We can oxygenate, and if there's some sort of external wound, we can either bandage it or we can make sure that we're keeping like eviscerated organs moist and warm. Um, Abdominal trauma is a situation where you may want to ensure permissive hypotension because you don't want to help them bleed out more. And again, no matter what trauma, what kind of trauma you are dealing with, rapid transportation is the number one key. There was a question earlier this week regarding hemostatic gauze. Sorry, again, the internet is unstable. As far as I can tell you in regards to hemostatic gauze, and this is for the city, it is only authorized for use in the penetrating abdominal trauma in the event of an active shooter. Okay. We do not regularly pack wounds. You will see in some of the national materials that they do want you to pack an abdominal with a hemostatic. Current protocols do not allow for that. Okay. Just keep that in mind. Danny, do you have a health bar over your head? Okay. Just making sure. Someone get him coffee. He's not 100%. Any questions on abdominal trauma? All right, cool. Cool. Next up. I don't remember actually. Orthopedic. And if I freeze at any point, someone let me know, because I don't know what's going on with the internet today. So, in case you all forgot back from BLS, you have the appendicular skeleton and the axial skeleton. Your axial skeleton is obviously all of the things associated with your skull, spine, and ribs, whereas your appendicular skeleton is everything else. Your skeleton is fantastic when combined with the muscular system because the two of them allow you to move. The muscles allow heat production, and combined they allow for postural maintenance. And this is the point in lecture where most people kind of sit and, oh yeah, no, we're going to think about my posture, right? So you sit up nice and straight. For the most part, patients who are suspected of having trauma to an extremity should be treated as though there is a fracture, okay? Tenderness, swelling, discoloration, all of these things what's the right word? All of these indicate that there should be a level of splinting occurring, or at the very least an ice pack, okay? Splinting is ideal for orthopedic injuries because it helps reduce the amount of motion that the patient can participate in, which means that they're not going to create further neurological or vascular damage due to sharp, pointy bone injuries. Trauma to the bones and muscles are caused by direct trauma, indirect trauma, and pathological conditions. A fracture is considered any break in the continuity of bone, okay? Not only can it be an actual physical full break, but you can also have stress fractures, which can create a weak point in the bone, which is also like edema, and it can cause a weak spot while the stress fracture exists, which creates a higher possibility of that pathological fracture event. Long bone fractures can result in significant hemorrhage depending on what they are. And we talked about this a little bit last week, right? So your tib fib is about 500 milliliters, a little bit more. Femur is about 1 liter of blood. Your pelvis about 2. And your pelvis can also hold more than 2 milliliters of blood. You can, if you opened up somebody's abdomen and just poured blood in, their pelvis and poured blood in, it can hold up to about 4,000 milliliters from other sources. So if you have a combined abdominal and pelvic injury, you could have a significant amount of blood in that area. Sprains, so there's a difference between a sprain and a strain, okay? So a sprain is an injury of a ligament, whereas a strain is a muscle or tendon, okay? So the problem with a sprain is that ligaments have less blood supply than tendons and bone and muscles. So you may have a longer healing concern because of the lack of blood flow. They're rated on different degrees, right? So your first degree sprain is there's no joint instability, whereas second degree is there's some swelling and bruising, where a third degree is a complete tear, right? So if you've ever watched football and you watch someone get carted off the field with an ACL sprain, okay, they'll grade it and they'll determine if the patient needs or the person needs surgery to repair the ligament or not. The knees and the ankles are the two most commonly sprained joints, just based on how human beings move and the structure of the joint itself. Meanwhile, strains are an injury to the muscle or tendon due to overexertion or overextension, okay? This is like, you go to the gym for the first time in like 8 months, and you start working out and trying to lift things that you were lifting pre-corona, and you can potentially cause a significant amount of damage to yourself because your muscles are not used to that kind of weight, okay? Back strains are very common in EMS, right? Because all of a sudden we're moving that dialysis patient who weighs 450 pounds and we have no lift assist. Severe strains, however, can cause an avulsion of the bone, right? So the tendon is attached to the bone, and if it's a bad enough strain, either the tendon can disconnect from the bone and then they have to go in surgically and like pull the muscle back to where it's supposed to be. Because if you think about it, oh no, not what I wanted. Because if you think about it, your muscles are under constant stress. Okay, that's kind of what gives you some posture. So if you have, like, for example, a bicep, right? This is like probably the one I see most commonly. So your bicep, if you're like this bicep is stretched, okay, and your tricep is small. I'm having a brain day. So if this is flexed, this is stretched, okay? So relaxed, strained. So if you are doing some sort of intense workout or exercise and you actually disconnect the bicep, usually it gets disconnected down here, because the muscle is no longer being stabilized on both sides, it will go to the relaxed section. There's the relaxed pose. So the whole bicep will go bloop and go up towards the shoulder if it detaches from here. If it detaches from the other side, it's going to go that way. Okay? Joni, your face is like, what? No. So those are the things they actually will have to, if it does happen to be a significant tendon tear where the muscle goes bloop, they actually have to go in and surgically like re-stretch the muscle and then reattach it to the bony insertion point. However, if the tendon doesn't tear, but it puts a significant amount of pressure on the bone, it can actually pull a piece of the bone along with it, okay? If you also have a tendon like sprain or strain, the bone can actually become bruised, or start developing edema from the excessive amount of force that's being put on it because of the imbalances due to the strain. That's the word I'm looking for. It's Monday. It's a tough Monday. Other concerns, right? We have joint dislocations, right? When things are not in the place where they usually were. Most of the time, joint dislocations should be suspected when there's deformity with a decreased range of motion. I know there's plenty of people who can do like they can pop their shoulders out and stuff, which is weird and kind of creepy, right? But or the people who can wiggle their fingers around or pop things in and out, right? Not normal. You shouldn't be able to do that. A lot of the times, the ligaments and the tendons in that area can be damaged due to a dislocation. They can be stretched or strained. So patients who have regular joint dislocations, right, usually shoulders are very commonly dislocated, may experience like muscle and tendon pain due to the stretching. When you have a patient who has an orthopedic trauma injury, there could be a complete variety of different injuries that you will see. It could be someone is like, oh, I have some discomfort, right? And they're like just kind of chilling, and it's a significant break. Or you could have someone whose bone is literally sticking out of their body, okay? it can be a variety of things, and this is where you have to play good detective, okay? If there is pain on palpation or movement, you should be stabilizing that because it might be injured or might be broken. Swelling and deformity is like one of the easiest signs to miss, okay? Because if you don't do a good visual assessment, right, expose the patient, run your hands along the bone, check both sides for symmetry, for the deformity or swelling. Crepitus is by far the most creepy of the signs and symptoms that you may encounter. There's nothing quite like feeling bones rubbed together. Decreased range of motion, any unnatural movement, right? I think everyone has had at least one patient who, like, they've had an injury in their arm or their leg is going in the wrong direction. But the most significant is there's a decrease or absent pulse motor sensory. We talked about this a little bit earlier in the course, that if that's the one time that you have the potential for doing a reduction in the field, is if there is a absent pulse motor or sensory to the limb, because it usually means that there is either a disruption in the vasculature or the bone is crushing the nerves in that area. I just want you to know, I don't know who this patient was on the side, but this was a actual patient injury. Okay, this is a 3D rendering of their scan, their bone scan. I think it was an MRI. Number one thing that you're going to do in orthopedic trauma is assess for life-threatening injuries. Okay, right? Just like anything else for the most part. Don't get distracted by things that might be really grotesque. Things that you might not be able to see could be more life-threatening than anything else. For example, if you came up on scene and you saw this patient, but they also happen to have bilateral open tib-fib fractures, what's going to kill them faster? This open book pelvic fracture or the tib-fib? I think it froze again. Absolutely, right? That's 2,000 milliliters of blood. That's significant potential internal organ injuries, right? Like the bladder and stuff, or all in that region. You have right along the, I'll get my little pen, right along here in this region, right? You have the iliac arteries, okay? You could have, there's a lot of injury here. Okay, all of those things can lead to a lot of bleeding. It's a lot more life-threatening. So if you go up and you're like, oh, look at that, let me splint the tib fib, and you don't do a full assessment and actually check the stability of that pelvis, you might have some significant issues with that patient management. Don't forget your 6 Ps. They're always good to keep in the back of your mind, right? Pain, pallor, paresthesia, pulselessness, paralysis, and poikilothermia, which is just always fun to say. Splinting, right? Basic. We don't really, as ALS providers, don't do anything wildly special for the management of a trauma patient other than pain control and maybe some fluid resuscitation if it's necessary. Okay? But most important thing that you can do is splint. And I will say, generally my approach to pain management always starts with, here's an ice pack, right? You want to start small and work your way up, because if you go and start with 100 micrograms of fentanyl and it doesn't touch their pain, you have nowhere left to go. Immobilization of those injuries are very helpful. It helps reduce bleeding and the concurrence or the collateral damage from broken bone ends. If it is an open wound, it can help decrease contamination because you're limiting the amount of material that can get in there. There's a variety of different things that we can do. Obviously, we have the rigid splint. Soft splints such as pillows for the ankle are helpful. Traction splint, which is always fun. I highly recommend taking your traction splint out of the ambulance every once in a while and reminding yourself how to use it, because people don't use it often enough. In the event of an upper extremity injury, the most appropriate method of splinting is usually the sling and swath, okay? Again, These are things that people don't necessarily do all that often. So you may forget, which means you might want to refresh your memory. Usually you want to make sure that the injury is kept well and close to the body to reduce the amount of motion and otherwise like pain. Here's a sling and swab. Remember, don't ever tie anything over the actual site of the injury, no matter how you're splinting. Put your cravats on either side of the injury. Make sure that if you are putting a knot against skin, that you're padding it. There's a solid shoulder injury for you. That's a nice dislocation, right? You can kind of tell if you look at the difference between the one arm and the other, right? A regular looking shoulder has that nice round kind of look to it, whereas the dislocated shoulder just doesn't look right. Most of the time, shoulder dislocations and or other injuries are due to falling out on an outstretched hand, right? That forces are transmitted all the way up to the shoulder, which is the end of the line, and it kind of either pops out or fractures up high. Excuse me. Rotator cuff injuries are also super common, right? So you have all those muscles that are across. Let me just get the pen. Across the shoulder. All right, as a human beings, we don't really tend, right here, right? You have your rotator cuff, and on the back you have some too. We don't work these well enough, like pretty much ever. But especially in EMS, we do a lot with those muscles, and they're kind of smallish muscles. So you go to move somebody and you kind of yank wrong, or you try to pick something up and it's too heavy and it pulls your arm down, or you start to try to go around a corner and you're moving your arm strange, right? This is why you want to keep, everything, the weight close to your body, keep your elbows tucked in, because once you start moving it out, you're increasing the lever of your arm and putting more strain on the joint. So all of these little muscles are not necessarily able to keep up, okay, with the strain. Bulky padding is usually helpful for keeping the arm in place. While most shoulder dislocations are anterior, I have seen at least one posterior shoulder dislocation, which was during, I believe, jiu-jitsu. He was in a hold and his shoulder popped out and he could not lower his arm over his head, which unfortunately the doctor was like, I hate to tell you this, but that's how we put it back in the joint, is you take the arm and you go poof and you drop it back down to where it's supposed to be. That guy was in a lot of pain, and BLS transported him. They were like, we don't know how to splint this. Okay. Here's Grandma. She's over here doing some push-ups. If the humerus does not actually dislocate, you can have mid-shaft fractures, or a variety of other fractures, depending on the patient's age and bone health. I like here, she looks like she's seriously doing some G.I. Joe vibes. If there is a significant damage, sometimes you won't even notice, right? The patient might just be reluctant to pick up their arm. I know that we had this at here at one point. They had a patient who was involved in, I think, an MVA or a fall. And the patient was fine, just didn't want to lift up his arm. Like, okay, a little intoxicated. Get to the hospital and they called a stroke note because the patient wasn't lifting his arm. Turned out that the humerus was fractured. So, it can happen that the patient won't necessarily present right away. But you also have to realize, which is kind of wild, depending on what time you arrive on scene, right? So if you get there really quick, your body does this really cool thing called self-splinting. Okay, so basically all of the muscles in the area actually start to just contract, which is why when you have a patient with a femur fracture, you see the quad going like this, okay? It's trying to keep everything in one place so you don't create more damage. So if you have a very successful like a humerus fracture, and the patient's muscles are doing what they're supposed to do and contracting, you won't necessarily feel like a deformity yet. Once the muscles start to get tired, that's when you start to feel, the wiggle in the bone or the instability in the bone. So keep that in mind. This is why we assess and reassess, and this is why we splint even if we don't necessarily find something, because it has the potential to exist even if it doesn't show up yet. Humerus fractures again, right? We sling and swath. Usually, I don't know anyone who's actually used a board splint. Nerves. There's a lot of nerves that run through there also. This one. Elbow. Little kids very commonly have elbow injuries, okay? Most of the time it's called the nursing elbow, where someone grabs the kid by their arm and pulls them up and out of the way, usually out of some level of danger, and it can just kind of stretch the joint space. So they might have a little dislocated, and the little kids don't usually say anything. They're just like, oh, it kind of hurts, right? Adults though, so this gentleman was doing a power clean and he lifted it over his head, and as he fully stretched his arm, his one elbow said, "Not today, brah," and his radius and ulna dislocated on either side of the humeral head, okay? Not a good day for him. There's the arteries, right, run through. If you draw in the artery, right, so the brachial artery is coming in right here, you have a potential for it to either be compressed or to be actually lacerated because of this not goodness going on right there. Elbow injuries, really, you want to kind of splint to the position found. It might be a challenge to splint this in the position found. You might not be able to get him in the ambulance, depending on how you're transporting. You might not have an easy way to actually splint this, right? So you have to maybe get creative with some pillows and some slings and cravats in order to keep that in a location where it's stable. Radius and ulnar, very common in kids, right? There's two that we really kind of they really kind of emphasize. One's the Colles fracture, which is when you're falling on an outstretched palm and you have an injury at the wrist here, and then the Smith's fracture. I don't know anyone who falls quite like that, but you're causing damage on this side. Most commonly, it's the radius and ulna, the distal radius and ulna that are injured. The carpal bones, right? All those bones here in the wrist can also be injured, which is considered a wrist fracture also, right? Most common fracture of the hand is the boxer's fracture, which is when you punch something with a closed fist and do it wrong and break the carpal, the metacarpal of your pinky finger, right? As you see right here, it's highlighted. Most of the time, hand injuries are due to contact sports or fighting, various crush-related injuries or equipment malfunctions, right? People who put their hands in places they're not really supposed to. What else we got going on the check? Yes, it's the Kyle punching drywall. Finger injuries, again, relatively common. A lot of kids will, kind of hurt their fingers in a variety of ways. Most of the time we manage it through what's called buddy splinting, which is when you kind of tape the injured finger to the one next to it. If you do happen to have something where there's a tendon injury, it's usually called mallet finger, which is when it kind of it pops down abnormally. You can't even necessarily, there's some people who can do it. I can't do it. It's a tendon tear. You also time it's patients who jam their hands or close their hand in a door or something to that effect. Lower extremity injuries, right? Anything from the pelvis down. Very associated with a lot of blood loss, not only because of large vasculature, but gravity. It's also because you need a lot more force in order to break these bones. These bones, especially the pelvis and the femur, are very structurally solid. The femur is the same density as concrete. So if you have someone who's otherwise healthy and they have a femur fracture, it's either a serious pathological concern that they have maybe bone cancer or something, or osteoporosis, or they were hit by, like, you know, a car. So they've experienced significant force, and there may be concurrent injuries as well. Pelvic fractures, right? Any blunt or penetrating injury in this area. We see this pelvic injuries, actually, like to the bone, the pelvis bone itself, can be more common in the elderly, usually elderly females who are at increased risk of osteoporosis. And these are the people who fall and then can't ambulate. Okay, pelvic binders are phenomenal. I don't know if anyone has used like a sheet to tie around the pelvis in order to stabilize it. Works really well, but you have to get, you know, some good traction on those knots as you tie them. In is out and out is in. Okay, great way to help you remember if it's a dislocated or a fractured hip. And when we talk about the hip, this is traditionally the femoral neck and or head. The neck is, I don't know who designed the human body, but the femoral neck is this like little thin piece of bone going from like the femur, the body of the femur, and then you have it going into the pelvis, and it's like this little tiny thin bone. You're like, this suspension sucks. Like, this was not well developed. So it's very commonly injured, right? It's at a 90-degree angle to, like, or almost a 90-degree angle to the rest of that bone. So it's going to experience the majority of the forces that be transmitted. Got my pirate on, apparently. So that's really what we're talking about. So in a hip injury, when you have a leg that's pointed in, it's traditionally dislocated, because if you think about how the bone moves, it popped out and it twists the whole femur. If the foot is everted, not inverted, it's very commonly a fracture, okay, because the bone gets pulled in the other direction because it's no longer in one piece. Dislocations are usually posterior in direction, okay? So just keep that in mind if you happen to see someone with an inverted leg. Hip dislocations are a little less common than hip fractures. Look at that dent in that femur. It's usually a result of major trauma. In child abuse, it's also relatively common. We talked about how the muscles are being stretched by your bones, right? We talked about with the bicep, the tension is released. It kind of goes into back to where it wants to be. This is also what happens if you have a femur fracture, right? So you have this big, think of it like a tension rod, right? You know, like you're hanging up curtains. You have this tension rod and it's being held out. And that's your muscle, okay? If the walls suddenly aren't there anymore, it's just going to fall, right? So if that tension is released from the muscle, it's going to start pulling in and it's going to start quivering, okay? Because it's going into a spasm because it needs to be stretched out. This is why a traction splint works so well for relieving pain. The most significant pain that a patient with a femur fracture actually experiences is that of the muscle spasms from the muscle no longer being held at tension, okay? So once you pull that leg back to where it's supposed to be and the muscle is stretched back to its normal length, it can kind of relax a little bit and you'll actually watch the muscle spasms go away and the patient will experience significant relief. I keep hitting the wrong one. Hold on. Oh, go back. Oh, I was ignoring me. All right, cool. Well, femurs, that's it. Traction splints, they're great. Lots of blood can be lost in a femur fracture. Knee and patella injuries. I think everyone has whacked their knee against something and been like, I'm dying, right? They can be pretty painful when you just whack your patella. However, there's also other concerns where you have a lot of ligaments, right, that keep that knee stable. You have a meniscus inside, which is that padding that can be torn due to twisting, right? The twisting forces. The muscles and the tendons as well can be damaged due to twisting forces. And then you have the bones, all right? There's a lot going on at your joints. There's a lot of different pieces that are holding that joint stable. So when you have someone who has a joint fracture or joint injury, there's a lot of potential other things that are damaged that you need to keep in consideration. When it comes to a knee injury, you should splint it in the position found, which means you might need to do an A-frame. Do remember that we are now allowed on the BLS level to reduce a patella dislocation. So you have on your lower extremities, your tibia and your fibula. The tibia is the shin bone in front, while the fibula is just like this cute little support bone in the back. It is very challenging to just break your fibula. It's actually one of those things where if you have someone who goes to the hospital and they break just the fibula, like the doctor's like, guys, you have to come look at this. I don't know how they don't only broke their fibula. For the most part, the tibia provides most of your weight bearing, and is also not as well protected as the fibula, which is sort of embedded a little bit more in the muscle. Twisting injuries, direct trauma, all of these things can cause issues in the tib fib. Tib fibs also like to pop out of the skin. Just happens to be, I think, their thing. Your feet, right? There's a number of different injuries that can happen at the foot level. So you can have stress fractures in the phalanges and the tarsals. You can have ankle injuries, right, which is really a tib-fib fracture up high, right? So your medial malleolus and your lateral malleolus are actually the ends of your tibia and fibula, respectively. Heel injuries, right? So has anyone jumped off of something high and landed on your feet and been like, I regret this? You've probably done a little damage to your heels, right? You can have Achilles injuries, okay? Again, Achilles, having a little stroke, don't mind me. Your Achilles tendon comes in and inserts right around here, down low. So the tendon is stretched over the bone. It comes up to about here, around the height of your fibula, of the medial malleolus, like that pointy ankle bone that you have, and then it starts to turn into the various calf muscles, okay? So if you have someone who has done injury here, that like right above 2 inches above the heel, that's right around that spot where the muscle, the tendon turns into muscle, okay? That's a weak spot in most muscle tendon areas. That's usually where injuries occur, is right at in that transitional tissue. Just a little bit of extra fun facts for you. Toe stubbing, good way to break a toe, especially the pinky toe. Has anyone accidentally almost ripped their pinky toe off? I think everyone knows what that feels like. Patients who don't really want to bear weight on the foot, usually you would suspect that there's probably some level of injury going on. Definitely had a job once where a lady had one of those like jazzies, and it came over as chest pain, but it was a toe injury. She was zipping around her apartment and she cut a turn too close and almost ripped her pinky toe off. But somehow that was chest pain. Open fractures. Open fractures are a little more complicated than closed fractures, obviously, because you have a higher risk of infection. And again, you want to also kind of consider that it might be a higher index, like a mechanism of injury, or a higher suspicion of an increased mechanism of injury. Again, you also have the potential that it's a person with a pathological issue, right? Older people have thinner skin, so there's a possibility that they just happened to not be able to contain the sharp bone. You want to make sure that you're covering bone ends in sterile saline moistened gauze before you do splint. Okay, patient might also appreciate just a smidgen of pain relief. Fractures, so the really wild thing is a bone that has fractured will actually be stronger than the original bone because of the the bony scar tissue that heals over the area, right? It creates this kind of callus, and it actually becomes stronger than the original bone. And this is going to sound ridiculous, but I would rather break a bone than tear a muscle, because when a muscle heals, it never heals 100%. Okay? So a bone injury is, as much as it sounds horrible, is a better injury to have, because as long as your nutritional status is in good shape, you will heal better. Depending on the healing process really depends on a number of things. So one, how strong was the bone before injury? What's the use of the bone, right? So if it's a frequently used bone, it might take longer. Where was the break? How big or how bad was the fracture, right? Because sometimes you need surgery to put the bone back together, because just putting it in a cast or splinting it out is not going to be sufficient. And what other like comorbidities exist, right? So if you have a patient who has, pre-existing osteoporosis, or is malnourished, or has some sort of vitamin D deficiency, that bone's not going to heal as well as, someone who's in better health. The possibility also exists for osteomyelitis, especially in the event of an open fracture where that bone gets infected, which is going to delay healing. Here we go. I don't know if anyone remembers from when we did the BLS update. Here's how to reduce a dislocated patella. A little bit, just a little bit of pain control. It depends on how nice you're feeling that day. Again, we talked about reducing fractures. Really, you want to make sure you're doing that. I think I'm back. You want to make sure that you're doing that in the event of loss of PMS. Same thing with any sort of limb-threatening injury, loss of PMS. Don't do elbows. That's a lot of potential for nerve and vascular damage in that area. And when you are doing a reduction, you're doing gentle, firm traction. I think that's it. That's it for ortho. Questions, thoughts, concerns? You can do other limbs. So like if you have somebody who's got, I've actually seen this one. I had the FDNY crew brought in a gentleman who had a tib-fib fracture. It was a closed fracture, and his foot was blue, and they did not reduce in the field. That was their opportunity to reduce. Okay, like this, it went from being like, oh hey, this like, oh what's your guy's problem? Like, oh he's got like he's a tib fib fracture, and they took the sheet off and it was purple, and they're like, I need a doctor stat, and I'm like, how did y'all not realize that? And this is why you assess and reassess, because you need to make sure that the PMS is still in existence. And this is also why you assess before and after you splint, because if it was there before and then not afterwards, it's a problem. Yes, the Mr. Deed scene with the dead foot. Exactly. I've actually had a lady who had a black, dead, gangrenous foot also. That was really gross. Oh, the patella? I don't even know that one from Mr. Deeds. Yeah, patellas do got a little wiggle to them, but yeah. Anyway, so yeah, so now you're a BLS, you should have been in service. I'm sure all of your departments have thoroughly in-serviced you on how to reduce a patella. um, that is a potential that you have, is to put that bad boy back in place. Um, I don't know. You've done it? Mm-hmm. How'd it go? Did it go smoothly? You shouldn't have already made him. He needed to go get X-rays. Uh, wow. Zero, zero shit's given. Yeah, that sucks. Yeah, well, that's someone who like you sent to physical therapy. Like you need to go do like 800 squats like now because your knee's gonna keep popping out. Um, yeah, younger kids are also a little more they'll heal better because they do have a lot looser ligaments and tendons for a few years. And once that kid starts hitting like 18, 19, he's gonna pop it out and he's gonna not bounce back as nicely, which is gonna be not a good day for him. It usually won't go. If it's dislocated, it won't go down, most likely. But if there's a tendon, and that would, how do I put this? If it's a tendon tear and it's going down, it's not going to go down. If there's a tendon tear, it's more likely going to be underneath the patella and going up because that muscle is a lot stronger, as opposed to the muscle in the front of the shin, like that's attached to the bottom of the shin, is not as strong as your quad, so it's not going to like fall down as readily. But yes, that wouldn't necessarily be a dislocation. Cool. Any other thoughts before we do environmental? Y'all get real quiet. Like, no, let's do it. All right. So, environmental. As we daylight saving time and we all wake up and it's freaking cold outside, there's some things that we should consider. Now, what are we doing? Okay. So, number one, thermoregulation, right? This is your body's ability to maintain body temperature in a variety of conditions, right? So, for the most part, your body's 98.6-ish, right? Some people run a little hot, some people run a little cold. This is all controlled by your posterior hypothalamus. So as it starts to receive information from your body regarding what the temperature is, it will either increase your thyroid activity or decrease it, in order to, and a number of other things, in order to maintain the temperature, right? So if you're chilly, your body's going to say, we need more energy. So it'll ask your thyroid to release, T3 and T4 to start increasing your metabolism. Your muscles will start to shiver, which helps create just heat. And you'll start breathing a little slower because a lot of heat is expelled from your body through your lungs. So if you're hot, you'll breathe faster. Your thyroid action will slow down. Your metabolism will slow down, and you'll shunt blood to your skin. Okay, these are all things that happen on the regular throughout the day that you never really have to think about, right? The most you'll have to think about is, it's a little chilly in here, let me get a sweater. Your body, and this is why some people run a little hotter and some people run a little cooler, is that your body has a set point, right? It's got its own thermostat. And this is why when you get sick, you run a fever, is because your body recognizes that there's something wrong and it turns the thermostat up. Because if you are hotter than 98.6 or 37 degrees centigrade, you no longer are a habitable environment for this invading bacteria or virus. Oh. Super. Just once? Dear. All right. I'm here. Yeah, back on my phone hotspot now. Ridiculous. All right, cool. Let's go back to this real quick. Where did you all lose me? Gotcha. This one. Glad I moved on to a whole other slide and talked to myself. All right, so yeah, so your body calls for increased metabolism, right? So you have this increased burning of sugar, and the glyconeogenesis and such is going on so that your body can stay warm. So your muscles are shivering, that generates heat. Your breathing will slow down because your body actually expels a good amount of heat through breathing. The process of breathing. If you're cold, the blood will shunt into the middle of your body, which is why people get mottled or get like very pale when they're cold. But meanwhile, on the other side, if you're hot, your body will shunt blood to the skin to help get rid of heat. You'll breathe faster. Your metabolism will slow down because you don't need to burn as many calories in order to maintain your body temperature. So your body's hypothalamus kind of serves as the thermostat, right? And this is why some people run hot and some people run cold, because everyone has an inherent set point. And this is also why when you get a fever, you start to get hot, is because your body goes, oh, this is an invading bacteria or virus. Let's make ourselves uninhabitable. And it raises the thermostat in your body to help kind of kill the bacteria or virus that's trolling around. 98.6 is maintained because it's an optimal environment for your normal cell metabolism. Too hot and it doesn't work well, too cold and it doesn't work well. So your body likes that in-between spot. Thermogenesis, right, is the creation, genesis, the creation of heat, thermo, or thermolysis, the breakdown of heat. So this is shivering is thermogenesis. Panting, right, when you're really hot, is thermolysis. You're getting rid of temperature. Your body will traditionally generate heat if it's cold. This is again brought to you by your thyroid, fat metabolism, muscle shivering, constriction of blood vessels at the skin level. Age, right? Older people are not able to do this as well. General health, right? If you're sick, you're not going to do this as well. If you're taking, beta blockers or stuff like that, you're not going to be able to do this process as well. And your nutritional status, right? So this is, if you are anorexic, for example, you don't have, adequate muscles or body fat to help keep your heat inside. Here's just a breakdown of how your body will produce heat. Mechanically, it's through shivering and vasoconstriction. Chemically, through cellular metabolism. Metabolically, through breakdown of brown fat. And endocrine heat production is through your hormones released from your thyroid and your adrenals. In order to keep your body nice and cool, you will lose heat to the environment through three methods. One, your skin, obviously, right? You'll sweat, and that evaporation from your skin will help cool your body down. Accelerated respiration, right? You're blowing off that heat, sort of like when you have high acid levels, you'll blow off the acid, and excretion, right? So this is kind of up there with your perspiration. You're getting rid of you're producing heat through sweat through the dilation of cutaneous vessels in order to get it off. 4 things that you do need to remember in regards to heat loss are radiation, conduction, convection, and evaporation, right? Because these are both normal and abnormal ways that you will lose heat. For example, if you are a homeless person who is laying on a cold concrete slab, you are going to be losing heat through conduction. If you are outside and it's breezy, you are losing heat through convection. If you are sweating, right, you have sweaty skin, and this is the evaporation route. And radiation is just that normal between you and the environment. It just happens regularly. So these are things that you have to take into consideration, even if it's, especially if it's not a normal way that a patient is losing heat. Because, grandma's laying on the floor for 4 or 5 hours. She might be hypothermic. You might need to, warm her up. Okay? These are things you need to take into consideration during patient assessment. And here's just another quick review of how heat is lost from the body, which we just talked about. And here's a picture of it. Because people learn in different ways, and sometimes you need just a different picture. And remember this dog that needed to be rescued? There's a number of different environmental factors that will contribute to a potential environmental medical emergency. Probably one of the number one environmental medical emergencies that is experienced is when people go hiking and don't anticipate the weather change. So they don't anticipate for rain. They don't anticipate, for example, like the desert. The desert in Arizona, New Mexico, Nevada, in that area has significant temperature swings. So it might be 120 degrees during the day, but 40 degrees at night. Okay, so people have not necessarily prepared for that 40 degrees at night because they didn't think of it, right? Atmospheric pressure is another concern. Terrain, right? So as you go up in elevation, it gets colder. And there's all the other traditional patient factors that kind of are at play when it comes to an environmental issue. Hyperthermia, okay? They love to ask at least one question about hyperthermia on the state. It's pretty much how do you determine the difference between heat cramps, heat stroke, and heat exhaustion? Like, what are your levels, right? So heat cramps is you sweat a bunch, and you kind of got rid of some too much salt, right? You're maybe a salty sweater. You'll have some cramping in the muscles, easily fixed with replacement of electrolytes. Heat syncope is like the patient starts to pass out, or heat exhaustion. Heat syncope, heat exhaustion. The patient might still be wet. Heat exhaustion is usually when the patient is severely dehydrated. They require fluids, okay? And then heat stroke is the core temperature over 104, okay? This is the patient's going to potentially have significant long-term issues with that. The most common cause of hyperthermia is excessive exercise in high temperatures, okay? And failing to drink an adequate amount of fluid to keep up with fluid loss from the system, like the sweating. So heat cramps, right, is brief intermittent muscle cramps caused usually by sodium and water loss. At high temperatures, you can lose about 1 to 3 liters of water an hour without you really noticing. And that 1 to 3 liters is usually carries with it about 30 to 50 milli equivalents of sodium. Usually the core body temperature is normal, right? The patient is still able to kind of regulate their temperature for their internal core temperature, but they might be very hot to the touch, very sweaty, tachycardic. Best course of action is to remove from the heat that they're in, right? Number one, any environmental emergency, we remove them from the heat or the cold, right? Put them in a temperate environment. Heat exhaustion is usually severe cramps with profuse sweating. The core body temperature will start to rise around up to 103 degrees. Again, this is where you need to maybe actively cool this patient, get them in a cool environment. You could spray them or put a cool, damp cloth on them to kind of help. Patient may experience fainting, nausea, vomiting, other orthostatic changes that are indicative of dehydration. Now, heat stroke is when the body goes, well, it's been real. I am now a cooked turkey. Altered mental status. Sometimes there will be a cessation of sweating due to severe dehydration. A patient might still have some ability to sweat. The core body temperature is now over 104 degrees. Okay, 104 degrees is like the cutoff, because even if you're outside exercising, they did this really interesting like study on sports science where you can push your body to like the braking, but the second you hit 104 degrees, your body goes nope and just shuts you down. So if you actually, like, they did a study where they had athletes eat ice before they started doing an activity, and those who ate ice had a longer time to temperature failure, reaching 104 degrees, than the other ones who did not. It's an interesting study. There's two types of heat stroke, classic and exertional. Classic is you are in a hot temperature and no longer able to moderate your body temperature. And exertional is it's not necessarily hot out, but you are doing a physical activity that is raising your blood core body temperature. Other problems associated with heat stroke include potential clotting disorders and dysrhythmias due to electrolyte imbalances and liver failure. Oh, here we go. Here's your classic heat stroke, right? Very young, very old. People in poorly ventilated homes without air conditioning. And people who usually have some sort of concurrent disease, right? The elderly, right? Like grandma who's inside with 3 sweaters on, the windows closed, and it's 90 degrees outside. And then you have exertional heat stroke, which is usually the young, healthy patients who are doing something very physically challenging, right? Athletes, football players in particular, military recruits, firefighters. These are people who will push and push until their body can no longer handle it and can no longer dissipate the heat. This is the reason that a lot of in August you hear like once a year there's usually like a high school football player who dies from heat stroke. A patient who is experiencing heat stroke will have a rapid respiratory rate. They will be tachycardic because now our heart is trying to push more blood to the skin to radiate heat out to the environment. And there will be a lot of sweating. Once upon a time, I had a cardiologist's office tell me that a patient was hot because they were tachycardic. It doesn't quite work like that. You don't generate heat by raising your blood temperature or your heart rate. It's not like your heart's in there like a little stove. Your body creates its heat elsewhere. It's the process of pushing the blood to the skin that is helping, right? And the same thing, if your patient is hypothermic, their heart rate's going to decrease because now you've decreased metabolism. And you're also going to keep a lot of that blood in the core because that's where your important organs are, 1. And 2, you don't want to put the hot blood to the cold skin and then lose that heat to the environment. Okay? Just a little sidebar there. Nurse practitioners who don't understand how tachycardia works. Some different the nice little table for you in the differences between exertional and classic. Not things that you're going to be tested on, but sometimes good to know. For example, in exertional heat stroke, you will have the patient may be presenting with rhabdo and renal failure because of the act of exertion. Number 1 way to manage hyperthermia is to move the patient to a cooler environment. State test question. If there is any sort of restrictive clothing, you should remove it because you want to have that person's body move as much hot blood to the skin as possible to offset temperatures. You want to be careful when you're cooling the patient because if you do it too quickly, you can actually create rebound hypothermia and the patient will start to shiver and then raise their body temperature just as badly. Make sure you check the blood sugar. If there is seizures, you control them, right? You're managing symptoms. And definitely make sure that you monitor EKG on these patients because there might be dysrhythmias due to the heat as well as electrolyte imbalances. On the other side of the spectrum, you have a core body temperature of less than 95 degrees, which is indicative of hypothermia. Um, Again, it can be caused by a number of things. It's either a decrease in heat production, right? So malnourishment where your body cannot, generate appropriate hormones and or shivering mechanisms, an increase in heat loss, right? You're wearing a bikini in the snow, or a combination of the two. A number of different things can cause it, right? Obviously, metabolic, which we just talked about really quick. Neurologic issues, right? The patient who's maybe had a stroke and fallen on the floor and can't get up and then starts to lose heat. Trauma, again, right? We strip trauma patients down, but we need to make sure that we cover them back up because they might have a metabolic issue in producing heat and infection. So the number one thing that you start to see in hypothermia is that the vasoconstriction starts to bring blood to the core, right? This is, anyone who's ever had somebody who's got cold hands and feet, they're not necessarily hypothermic, but that's the idea. They're shunting their blood to the core because they don't want to lose heat to the environment. Metabolism, heart rate increase, initially, right? Because your body's trying to compensate. As your hypothermia gets worse, the body's metabolic rate starts to slow down and it goes into like that hibernation mode. So because the metabolism is so low, it doesn't require as much oxygen, so the heart rate will decrease. Muscle tone will start to increase as it generates heat from shivering. Your body can only keep this up for so long, okay? This is why we need to make sure that they're toasty. Once the core body temperature hits 86 degrees Fahrenheit, you will no longer shiver. Okay? The body goes, okay, we are too cold for metabolism. We no longer have glucose or glycogen available to us. We're shutting it down. Okay? It goes into like a hibernation sleep mode. And then once shivering stops, you're not fighting the cold anymore, so you just get really cold really fast. One of the telltale signs of hypothermia, not only in environmental hypothermia, but also hypothermia secondary to like sepsis, for example, is what's called an J wave or an Osborne wave, which is this, it looks almost like a bundle branch block, right? You got those like the bunny ears, but it's a large, extra rounded wave that's kind of attached right to the QRS. So where you would kind of expect to see like right here, like ready? You maybe say like the T wave over here. You don't see a T wave. It starts to kind of inch up and go right into the QRS. More or less it's going, hey, I'm chilly, let's snuggle for heat. Most of the time the patient will deteriorate into a different a bradycardic rhythm. It may or may not be AFib, depending on where their body temperature is. But as a patient starts to get colder, their respirations decline, their pulse and their blood pressure go down. Bradycardia will not respond to atropine. Also, if you have a patient who is in cardiac arrest, it's traditionally not thought that you should give them epinephrine IV, because if they're super cold, that vasopressor is going to sit right in that frozen little vein, and when you start warming them up, that's when you start getting like a huge catecholamine rush to the heart because it was otherwise just sitting in their arm. Other problems that are associated with hypothermia is a lower acidic pH, right? Because you're not breathing as quickly. Some electrolyte imbalances may develop, and there's another thing called cold diuresis. So what happens is the body starts to move, the vasculature gets leaky, so the body moves the plasma fluid out into the third space. So these patients could be potentially very hypotensive also, secondary to cold diuresis. Your different classifications of hypothermia and the different levels that you have. Once you get to like, go ahead. Yes. Hmm. Yeah, definitely. Because if you have a patient who's hypothermic, also they're probably going to be seriously bradycardic, and they could go down all the way into like an asystolic kind of section area. They have had patients who have been uh, frozen and then successfully defrosted. There's a few cases of that actually happening, so this is why the EKG is important to help kind of guide your what you call it. Remember, they have to be warm and dead. Ted, yeah, yeah. Are a number of high risk patients we talked about are outdoor enthusiasts, the hikers and such, who are poorly prepared for weather or environmental other terrain conditions. But you also have your urban hypothermia, right? Your urban hikers or urban enthusiasts, homeless people, people who are older, right? Who perhaps fall on the floor and are unable to get up. Young children who are either I think this happens at least once a year. There's a small child in a diaper who wanders outside of the house into the snow, or kids who are not properly bundled up, right? Poor parenting preparation. And then people who have like concurrent medical and psychiatric illnesses, right? The combination of those two things leave them at a high risk. So, for the most part, we kind of exist here in the passive external and active external section. We do not really do a lot of active internal warming. You might perhaps do some warm IV fluids. If you actually have warm IV fluids on your freezing cold ambulance, that would be impressive. I've definitely taken the IV fluids and put them in front of the heater before you're administering them for a patient. But really, for the most part, we kind of hang out with warm blankets. Make sure you handle these cold patients gently, because you can send little ice crystals into their bloodstream and give them a stroke because of that. Go ahead. Yep. Yep. Mm-hmm. You would, yeah. Yeah, if you have hot packs. I don't know a lot of places that actually carry hot packs. That's awesome. You could do that. You could put it in front of like the forced air in the heater of the ambulance. You could call and get permission to maybe delay until the patient's warmer, the epinephrine administration. Um, we don't have, there's not a lot of really good ways to, in the ambulance, to warm patients up. But you can, I don't know, kind of work around it, I guess, in your own way. But that's one of those things where maybe you call medical control, say, hey, like, he's ice cold, he's in cardiac arrest, we're going to work him up. Can we withhold epinephrine until he's at the hospital and he's warmer? Because you have the potential for creating a huge epinephrine rush if it's just hanging out in whatchamacallit, their arm. No, it's a good thought that you just covered that slide for me. There you go. When you push it, whatever your IV site is, that's what I mean by the arm. It's going to hang out right by the wherever you've administered it. CPR and rewarming is going to be your precedent treatments. Remember, warm and dead. VFib and VTAC. There's no real research that supports shocking VFib and VTAC in the hypothermic cardiac arrest. Again, you do have your protocols, but that also does not mean that you can't call medical control and ask for advice. Um, because hypothermia does create such a slow metabolic state where the patient may be significantly bradycardia, you should be checking vital signs longer than 10 seconds that we, the traditional 10 seconds that we do. But if you don't feel anything, obviously start CPR. Effective ventilation with warm oxygen is helpful. Aspiration is a huge risk for any cardiac arrest event. You do not pace hypothermic sinus bradycardia. And again, we talked about this already now, that the cardiovascular drugs don't work in very cold temperatures in the body. Okay, the heart won't respond because it's too cold, if it even gets to the heart in the first place. And because the blood is being shunted away from the kidneys and stuff, you'll also have a potential toxic buildup of those drugs. So you want to use them with caution. Another version of hypothermia, or within the realm of hypothermia, is frost nip, which is transient numbness and tingling that resolves after rewarming. There's zero tissue destruction. This is when you go outside for an extended period of time and maybe forget your hat, and you get that red cold on your nose and on your ears, fingertips also. The next step is frostbite, where there is actual ice crystal development in the tissue itself. Again, usually happens in the fingers and toes because they're the most vulnerable at the ends of your extremities. There can be blisters that develop from the defrosting of the tissue, right, as that fluid starts to expand again. But the most damage is usually caused by ischemia. Small emboli are usually released after defrosting also, so you may have a patient who needs to be monitored for cardiac dysrhythmias and TIA symptoms. And then you have worst frostbite, which is, actual death of the fingers. Most of the time, frostbite is caused by a number of different predisposing factors, right? Mostly lack of protective clothing, or wet protective clothing, right? Because once it's wet and cold, it's even worse. The tissues at the local area starts to lose perfusion. So if you have someone who is a smoker, right, the perfusion in those fingers that they use to hold their cigarette is actually less than the rest of their hand. Alcohol and drug use is always a good predisposing factor, because sometimes you fall down, go boom, and then lay on something cold for hours at a time. Previous cold injuries are a predisposing factor, as is fatigue and poor nutrition. Poor nutrition is pretty common. Frostbite is now also level. There's different grades, right? So you have superficial frostbite, which is there's very minimal anticipated tissue loss, versus deep, where there might be amputating parts of fingers and such, and it's not going to heal. One of the things that happened a lot in not only, I think it was World War II, but Vietnam, was what was called trench foot. Less in Vietnam. They had more just like jungle foot, but it's wet feet in like kind of very cold temperatures. Most of the time it's due to like a moisture and cold. So the soldiers in World War II would stand in these trenches for hours at end, and if it was raining and their feet were wet, they were standing, they were cold, and then they would end up with this like swollen, blanched skin that then later becomes hot and swollen and very painful. If you've ever gone and like shoveled the driveway with like inadequate foot or hand protection, this is something that you might see, or something close to it, because this is very extended. Trench foot is considered much more an extended period of time. So, moving on to a brand new version of environmental dangers, drowning. So, drowning is usually due to respiratory impairment secondary to liquid. So submersion is when the head is underwater, and immersion is when you drown with your head above water. Drowning is the number one or one of the higher number one causes of death of children less than 5, and then people between 15 and 24, right? People who are taking risks that they shouldn't be taking. And then there's a number of different effects that drowning can cause dependent upon what type of water is aspirated and how much. So there's also 2 types of drowning. You have dry drowning and wet drowning. So the patient, when you see a drowning victim or you treat a drowning victim, what usually happens is your body tries to shut down the airway, and it does it through a laryngospasm. So as the larynx and the vocal cords snap shut, a dry drowning means that there's no water in the lungs, but there's no air going in and out either. Whereas a wet drowning is the laryngospasm actually releases and the water rushes into the lungs. All of this creates a brain injury, right, and brain death. So the lungs, right, so just like when you're not breathing any other time, initially your body will switch into anaerobic metabolism, which increases the level of acidosis that's going on. Respiratory failure is secondary to hypoxia, right? So you either have fluid in the lungs, or the fluid that got into the lungs washes out the surfactant, which causes the alveoli to collapse. Depending what type of water was aspirated, there could be contaminant particles, which if the patient is removed from the water successfully and resuscitated, they could end up with significant pneumonia problems. And then there's just damage to that space in between, right? When the alveoli collapse, that alveoli capillary membrane, right, that is also damaged. Usually kids, I'm going to say kids, but drowning victims can have delayed onset of their symptoms, right? So these are patients who really should be going to the hospital one way or the other to be evaluated, because it could be 24 hours later and they start having a difficult time breathing because the fluid in their lungs has now, the alveoli start to collapse because of the loss of surfactant. It could be a little delayed. Obviously, as with any other cardiac arrest or hypoxic situation, there's the potential for dysrhythmias, right? Which is then increases the potential for decreased cardiac output. And there's also what's called an anoxic brain injury, which is a potential global neurological event due to cerebral edema secondary to the hypoxia. Factors that affect the clinical outcome for patients, usually the duration of the submersion is number one. How clean was the water, right? Because if the drowning didn't, or the submersion didn't get you, the bacteria in the water could. How warm the water was. Your body actually loses body temperature extremely rapidly in cold water. I think it's 10 or 15 minutes. If you are submerged in 50-degree temperature, you will die from hypothermia in 15 minutes. And how old the patient is. The younger the patient is, the more protective their mammalian diving reflex is, and the less overall metabolism that the body needs because it's so much smaller. So this is why you could pull a kid out from a pool and they've been in there for 20 minutes and they can be resuscitated with no neurological defect, whereas an adult does not usually have the same outcome. No matter how long that the potential submersion time is, you should be doing resuscitation. Very similar to you need to be warm and dead. You need to be properly resuscitated in a submersion event. Quick review of some of the gaseous laws associated with diving and altitude injuries or issues. You have Boyle's law, which is at a constant temperature, when pressure is doubled, the volume of gas is halved. So as you go deeper into below sea level, your volume of gas gets smaller, okay? So which means as a diver ascends, the gas in their lungs expands, this is why when divers ascend to the surface, they're told that they need to exhale because the gas gets bigger. or the volume of the gas gets bigger. And you have Dalton's law. The pressure exerted by a gas remains the same when it is in a mixture. The pressure of the mixture is the sum of all the gases. So when you have the partial pressures of oxygen and nitrogen are changed depending on the pressure of the gas, right? So the higher you are, the less pressure of the gas. So that's why they say there's quote unquote thin air up in the mountains. This is why elite athletes will go to Colorado, which is about 10,000 feet of altitude, to train, because now they're training at lower partial pressures of oxygen. When they come back down to sea level, they will be more efficient at using oxygen, or so's the thought. And then you have Henry's law, which is at a constant temperature, the solubility of gas in a liquid solution is proportionate to the partial pressure of the gas. So as the pressure increases, this is the bends, right? This is the bends issue with diving. As nitrogen dissolves in blood, the pressure of it increases. So going into this a little different approach, here's Boyle's law in regards to diving. So as you descend, okay, the gas volume starts to get smaller, okay? Which means that as you ascend, the 17% gas volume that you have in your lungs turns into 100%, okay? Nitrogen also tends to dissolve, which gives you the issues of the bends, which we're going to talk about briefly in a moment. So as the patient starts to descend in a diving accident, they have what's called the squeeze. All the air that is in non-collapsible chambers is compressed. So patients usually have like inner ear issues, like if there's a eustachian tube blockage or like an ear infection or something, or they fail to exhale, that air will get trapped and cause compressive pain. Alternatively, there's the barotrauma of ascent, which is the reverse squeeze, which is now the volume of the air expands as you get closer to sea level, and the tissues, if they are distended, can't allow it to escape. So this is when you have patients who have lung injuries secondary to that, the overpressurization, right? A paper bag lung. It'll actually create barotrauma because of that expanding volume of oxygen. And here's that explosion-y vibe right there. Another problem is now with the reverse squeeze, as that volume of air starts to expand. If you do happen to have a pulmonary injury, barotrauma injury, that can create an air embolism that can then create can create a TIA or similar concerns. Most of the time, an air embolism status post diving is very dramatic. You'll have a person who's AMS, super confused, maybe experiencing loss of consciousness, vertigo, or other neurological deficits. They have this, they recompress you. This is how they fix this, is all a hyperbaric chamber. If you happen to be into scuba diving, highly recommend taking out scuba insurance, because if you have any of these injuries or concerns, they will fly you from whatever tropical location you are in the world to the appropriate hyperbaric chamber. So basically, they repressurize the oxygen that you have in your body, and the gases in your body, to maintain proper perfusion. This guy is not just really built. He's actually, that's a lot of subcutaneous emphysema, secondary to the nitrogen expanding in his blood and tissues. This is a diving accident. So as the nitrogen goes back from being dissolved in gas, it actually will start from dissolved to gaseous form, it will get trapped in the skin and tissues and cause something to this effect. Very painful. Obviously, the joints and the spinal cords are most affected. Joints because, the gas gets stuck at that corner. Other issues may experience are something like itching, rash, stuff like that. So Nitrogen narcosis, or which is also called the rapture of the deep, can happen at around 75 to 100 feet of depth of diving depth. Basically, what happens is there's too much nitrogen that's dissolved in the blood, and as it crosses the blood-brain barrier, it causes like alcohol intoxication. Okay, so patients start to have impaired judgment, may not be able to monitor their oxygen level or their breathing appropriately. And if you see actually in the background of this picture, the person who had suffered from oxygen or from nitrogen narcosis is actually, this person is dead. Just floating in the background. This person passed away after drowning because secondary to nitrogen narcosis. Things that you should get for diving emergencies, patient history. In regards to patient history, is the water temperature. When did the symptoms start? Did they take an airplane to get there? Because now, if you think about it, airplanes are pressurized so that we can breathe appropriately, and that screws up with all of the tissues and oxygen in your blood. Just similarly to how it happens with diving, but in the opposite effect. So it can exacerbate scuba diving injuries. Other things that you want to know is how many dives have they done in recent days. The more dives, the more at risk they are. What was their maximum depth? How long were they down at the bottom during the dive? Did they do safety stops? What's their dive gas mix? A lot of they're moving the scuba mix from like oxygen, nitrogen to maybe less nitrogen, or do they have a regular air, or do they use a different inert gas in the mix that would not necessarily create nitrogen issues? So a lot of different things that you would want to ask if you happen to work somewhere scuba-y. So things that we don't really see much in New York, because we don't really have tall enough mountains. Our tallest mountain in New York is I believe, just under 5,000 feet, is high altitude illness. Usually happens at around 8,200 feet or more. So you may see this in patients or people who are in like the Colorado Rocky region, right? Because those are much, much taller mountains than we have in New York State. Most of the time, it's caused by reduced atmospheric pressure, which results in hypoxia. The number one way to fix it is to come back down to a normal sea level. Also, don't sleep while at altitude, right? So going up and coming back down is a good way to prevent it. Carbs, high carb diet really helps also. I'm not really sure why, but it's a good excuse to eat carbs. So, acclimatization process takes a few days. So that's basically adjusting your body to less oxygen levels. Usually, acute mountain sickness happens within 4 to 6 hours, but will improve after a few days. Usually it's associated by like headache, nausea, vomiting, a little weak, a little dizzy, fatigue. Okay, because as you look here, as you start to go up in altitude, there's less oxygen. So at the very top of Mount Everest, you're only at 33% oxygen. Just like we talked about, here's Colorado's got 10. Here's your 10,000 or 11,000 is 66 at Vail Ski Resort versus Pikes Peak, which is 14,000, is 61% oxygen. The next step of high altitude sickness is high altitude cerebral edema, which is most severe form of the high altitude illness. This is with global cerebral signs and altered mental status, increased intracranial pressure. This patient will need hydration and dexamethasone, as well as a return to sea level. Hyperbaric therapy is also very useful. You actually see there's some mountain climbers who are super serious about the whole mountain climbing thing. Will actually climb with a hyperbaric tent, so that during sleeping that their stimulating sea level so they do not experience this kind of issue. Now, you can also have high altitude pulmonary edema, which is the most lethal. It's not end stage, but it's going to kill you. The increased pulmonary artery pressure that your body starts to develop in response to hypoxia, right? Because your body's like, where's the oxygen? You're like, oh, there's none up here. I didn't bring any. Your body starts to create like a inflammatory response. So those leukotrienes and all those other things that we talked about in other concerns, right? And like inflammation and infectious diseases starts to increase the vascular permeability, which means that your capillaries in your lungs start to get leaky, and it starts to fill up your lungs with edema. Most of the time, this is within a few days of beginning an ascent. It can be also caused by increased vigorous exercise, because again, remember, your lungs are now calling for more oxygen that isn't there. And descent is your definitive, just like, delivering a baby is definitive treatment for eclampsia. Descending is your treatment for high altitude sicknesses. CPAP is useful for the pulmonary edema. They also like to give Cialis or Viagra, and hydration, always helpful. We're all going to go mountain climbing now, right? Maybe diving. All right. Cool beans, guys. Any questions, thoughts, or concerns? No? Okay. Go ahead, Andrew. What happened? What you got? Mm-hmm. I don't think I've had one of those in the field, honestly. I will say, like, most likely that when it comes to an aortic dissection, a traumatic aortic dissection, you won't, by the time you get, unless it happens right in front of you, you're probably going to have someone in traumatic arrest. It's not going to be, that's a super lethal injury. No problem. That's it. We're all good. How are we feeling and confident going into review for this next exam? Feeling good. All right. If you I can't do Thursday, maybe Friday. All right. Sounds good. That way, you guys, if you have any other questions, would be good. Yeah. So maybe a Friday evening. BYOB. Best way to review. You're very welcome, guys. You're welcome. And if you guys want, we can do another review. We'll talk about this maybe on Friday. We'll do another review with a little more scenario stuff, so we can start doing some more protocols. And maybe we'll just pick another day to do that. And obviously, it will be in the evening and a BYOB, because it's just way more fun. All right, y'all. Have a great day.